Shortly, New York Presbyterian at Hudson Valley Hospital will be implementing a new IV heparin protocol. Heparin is a natural anticoagulant occurring in some immune cells of the body. It acts to prevent the formation of clots and the worsening of existing clots in the blood. It does not directly break up clots that have already been formed. Heparin acts in a complex interplay of molecules at multiple sites and factors in the coagulation cascade to effectively inactivate thrombin, a critical player in the last steps of the coagulation cascade that forms the fibrin strands and clots. Heparin also helps to prevent stabilization of clots. Anticoagulants are medications used to reduce the risk of pathological medical conditions caused by blood clotting and the formation of thrombus or embolus. Some anticoagulation medications include heparin, Coumadin or warfarin, Pradaxa, Xarelto, Eliquis, and Lovenox. A thrombus is a stationary blood clot formed on the surface of damaged blood vessels or inside the heart. Thrombi are dangerous because they may either occlude blood flow or may embolize. A clot embolizes when it breaks off of the vascular wall and travels freely in the bloodstream. Anticoagulant drugs help prevent this process from occurring by interfering with blood clot formation and stabilization. It has been proven that a weight-based protocol is more effective for patients in reaching the therapeutic threshold, along with achieving the therapeutic APTT range more rapidly than with a standard heparin protocol. This is the protocol we currently use. Moving forward, this will be the nomogram that we will use to initiate the heparin. Notice it is based on the patient's weight. Some important things to remember when administering IV heparin to a patient includes the following. Aspirin should not be administered during heparin therapy, except when clinically indicated for platelet inhibition. Non-steroidal anti-inflammatory medications should be administered with extreme caution during heparin therapy. All heparin infusions must be reordered and renewed on a daily basis. When initiating IV heparin, a heparin bolus based on the weight per table 1 is to be diluted in 50 milliliters of D5W or normal saline and given IV piggyback over 10 minutes or given IV push according to unit standards. Acute stroke, no bolus. Begin initial infusion. Ventricular assist devices, no bolus. Just begin the infusion. For DVT, PE, or other hypercoagulable disorders, 80 units per kilogram should be given. For AFib, 70 units per kilogram should be given. And for acute coronary stroke, 60 units per kilogram with a maximum of 5,000 units should be administered to the patient. For the initial infusion, using the pre-mixed 25,000 units in 250 ml of D5W or half normal saline will be administered based on the weight per table 1. First step, a KVO line may be turned off during heparin infusion. DVT, PE, acute stroke without the bolus, or other hypercoagulable disorders start at 18 units per kilogram per hour. For AFib, 13 units per kilogram per hour. For acute coronary syndrome, 12 units per kilogram per hour with a maximum of 1,000 units per hour. For acute coronary syndrome, 60 units per kilogram, maximum of 5,000 units. Ongoing lab work and monitoring of labs. All APTTs must be done via peripheral venipuncture or non-heparinized line. No draws through heparinized lines. First, draw an APTT 6 hours after heparin initiation or any change in heparin dose according to the APTT results. When a therapeutic APTT is achieved, repeat APTT in 6 hours for confirmation. Once 2 consecutive APTT levels are therapeutic, daily APTT levels must be drawn to ensure therapeutic level maintained. Interruptions in therapy. If for some reason the IV line comes out and is out for less than 1 hour, you may resume the heparin at prior dosage and draw an emergent APTT 6 hours after resuming infusion. If the IV line is out for more than 1 hour, rebolus as per Table 1 and restart infusion as the most recent maintenance rate. It is the nurse's duty to constantly assess vital signs and symptoms of bleeding on a patient with an IV heparin drip. Signs and symptoms to look for include bleeding gums, nosebleed or unusual bruising, black tarry stools, hematuria, a fall in the hematocrit or the blood pressure, guaiac-positive stools. Also monitor the patient for hypersensitivity reactions, chills, fever, urticaria. Observe injection sites for hematoma, ecchymosis, or inflammation. If for some reason your patient needs heparin reversal, this requires a separate order. Protamine sulfate is the drug to use. For any management questions, please contact the hematologist or the physician who ordered the heparin. If immediate reversal of heparin is needed, administer a pro-time dose of 1 milligram protamine sulfate per 100 units of heparin received in the previous 2.5 hours to a maximum dose of 50 milligrams of protamine sulfate. A test dose of 1 milligram protamine sulfate may be administered if clinically permissible. Administer appropriate dose or IV piggyback over 10 minutes with a maximum of 50 milligrams over 10 minutes, except in the OR. Draw an APTT or PT 15 minutes after the protamine is administered. When switching therapies, which must be ordered by the physician, remember, switching from an unfractionated heparin infusion to low molecular weight heparin, the infusion may be discontinued just prior to subcutaneous administration. If switching from therapeutic subcutaneous low molecular weight heparin to an unfractioned heparin infusion, the UFH should be initiated within 1 hour of the next scheduled dose of the low molecular weight heparin. A bolus dose of unfractioned heparin is not required since the patient will be therapeutically anticoagulated.